is sperm with poor morphology. I thought क्योंकि डॉक्टर शाहीन की मीटिंग है तो सिंपल स्ट्रेट फॉरवर्ड मॉर्फोलॉजी क्या है और उसका ट्रीटमेंट क्या है उसका बात करने का मज़ा नहीं आएगा. तो आई डिड सम रिसर्च कि व्हाई स्पर्म मॉर्फोलॉजी इज़ इम्पॉर्टेंट. हम लोग सब we all think that there are three main semen parameters that are extremely important: sperm concentration, motility and morphology. Besides, पाकिस्तान का एक मेजर मसला पस सेल्स का है, पर वो ज़्यादा पाकिस्तान में है, ग्लोबली इतना बड़ा मसला उसको कंसिडर नहीं किया जाता. But these are the three parameters that are extremely important. Sperm count और sperm motility की importance काफ़ी हद तक क्लियर है. We have the data, we have so many publications जो उसको इंडिकेट करती हैं कि एक सर्टेन लेवल पे मोटिलिटी और काउंट होगा तो चांसेस ऑफ कंसेप्शन बेहतर होंगे. However, there are there's a certain debate around morphology. जो अभी तक वो डिबेट चल रही है और उसमें अभी तक क्लैरिटी नहीं आई. So I'll just go through some recent publications and then we can discuss where do we stand right now. So the objectives of the talk are, we are going to talk about etiology of male subfertility, semen analysis itself obviously, classification of different sperm morphologies, assessment, how do we assess sperm morphology in our daily practice. Then, is there any clinical relevance of sperm morphology? करने का फायदा भी है sperm morphology के नहीं है. And third, obviously, how do we treat poor sperm morphology if there is any treatment available? We all know that male subfertility is a disease that affects the male reproductive system. There are various causes that cause male subfertility. Normally you can divide these causes into pre-testicular causes, testicular causes and post-testicular causes. Pre-testicular causes में congenital या genetic conditions आ सकती हैं. Then there are some anatomical problems that can be seen, hormonal or immunological abnormalities हो सकती हैं. Systemic diseases can lead to male subfertility. Sexual dysfunction is one of the causes. And then there are various lifestyle factors such as obesity, smoking, alcohol and many other which may be affecting a man's sperm count. The test semen analysis at times may not be able to detect the etiology of male subfertility. We all know that. It affects about 7% of the male population and it contributes to as high as around total cases of infertility or subfertility. हमारे अपने क्लिनिक के अंदर, लाइफ के अंदर हम अपना डाटा को रिव्यू करते रहते हैं. नॉर्मली मेल इनफर्टिलिटी हम 40 to 45% केसेस के अंदर देखते हैं. फीमेल जो है 30 to 35 में देखते हैं. So we even in Lahore we get more patients with male subfertility than female subfertility. And then obviously there are certain with जिनमें दोनों होते हैं and then there are unexplained cases as well. So it's pretty high. Just to recap, जो हमने मेडिकल कॉलेज में पढ़ा था कि what are the different stages of spermatogenesis. उसमें in the first stage these cells, the germ cells, undergo a mitotic division in which basically the number of cells increase. The number is amplified. Then in the second phase they go through the two meiotic divisions in which basically they lose their chromosomes. Half हो जाते हैं. Half sperm से आते हैं, half egg से आते हैं और फिर मिलके 46 chromosomes बनते हैं. तो through the meiotic divisions they lose their chromosomes, and then in the final stage these non-motile spermatozoa are transported into the epididymis. Epididymis में उनको motility भी मिलती है and it is also the storage for spermatozoa. All these activities take place in the seminiferous tubules and from there They go into the epididymis. Normally they're stored in the head of the epididymis, and when times come for ejaculation, they move through the various parts of epididymis and the ejaculatory duct and the urethra for ejaculation. What are the main key steps for fertilization? A sperm has to do a lot to ensure fertilization of the oocyte. It is not a very simple, straightforward process. Hence, the quality of sperm is extremely important अगर उसने egg को naturally fertilize करना है. Obviously, at the time of ejaculation, we're talking about natural conception right now. At the time of ejaculation, sperm has to have motility. Then it goes through two main reactions which are called the capacitation and the acrosome reaction. Then there is sperm egg fusion, which leads to activation of the oocyte or the egg, and then the initiation of embryo development takes place. Obviously, हर एक step की detailed discussion की जा सकती है, but this is not the platform for that. This is just to give you an overview कि these are the various steps जिसके through egg को fertilize किया जा सकता है. Semen analysis has been around since like 1930s. It provides valuable information for investigating of disorders and pathologies that affect the male reproductive tract. Routine semen analysis is the only gold standard test which is still carried out to assess the fertility potential. But routine semen analysis की अपनी बहुत सी limitations हैं. बहुत दफ़ा हम अपने clinics में एक single normal semen parameters की report देख के husband को बाइज्जत बरी कर देते हैं कि जी ये साइड पे हो जाओ और बस फिर जो फीमेल पार्टनर है उसके पीछे लग जाओ कि जी क्यों नहीं बच्चा हो रहा. बट इस तरह से नहीं है. सिंपल सीमेन एनालिसिस की बहुत सी लिमिटेशन है. उसमें स्पर्म का फंक्शनल पोटेंशियल हमें नहीं पता चलता. WHO guidelines they started in 1980 और लास्ट ईयर in 2021 उसका 6th edition आया है. Obviously, over the years जो parameters हैं वो ये लोग revise करते रहे हैं, and especially if you look at morphology देखें 1980 में 80% more than 80% के ऊपर थी, and then आहिस्ता आहिस्ता drop करते करते over the years in the 5th edition and the 6th edition in 2010 and 21 it has come down to as low as 4%. आप लोगों ने कभी सोचा इसकी क्या वजह है? 80% कहाँ, 4% कहाँ? बाकी आप पैरामीटर्स देखें तो उनमें कोई बहुत ज़्यादा ड्रास्टिक चेंज नज़र आपको नहीं आता. 20 मिलियन था 15 हो गया, 40 था 39 हो गया. You know, there's not much change in rest of the parameters. Morphology has been drastically reduced from way more than 80% to as low as 4%. What is a normal sperm as defined by World Health Organization? ये बड़ा interesting है. A normal sperm as defined by World Health Organization should have a head with an acrosome, midpiece and tail. The head should be oval. The acrosome should clearly cover the interior portion of the head to as much as 30 to 60%. Midpiece should not have any cytoplasmic residues. It should be attached to the head without forming any definitive angle. The tail should not have any cytoplasmic residues. Inserted to the post-acrosomal end of the midpiece with a length of 45 to 50 and no sharp bends. ये तो वो बात है कि जी रिश्ता लेने गया कोई लड़की अच्छी नहीं लग रही क्योंकि इस क्राइटेरिया पे तो कोई नहीं फिट हो सकता. ये सारे अगर आप पैरामीटर्स ढूंढना शुरू कर दें तो बहुत मुश्किल से कुछ चंद ही स्पर्म होंगे जो इस क्राइटेरिया के अंदर फॉल करेंगे. Hence, WHO has been reducing their morphology criteria from 80% to as low as now 4%. How do we assess these sperm morphology? Sperm morphology routine semen analysis में has to be assessed by staining the slide. We cannot just assess morphology by just looking at the slide, we have to stain it. Or the andrologist needs to count 100 to 200 sperms per sample to actually have an idea कि इसकी semen parameters क्या है. Unfortunately, we all know हमें semen reporting के साथ क्यों issue होता है, क्योंकि हमारे जो report करने वाले analyzers हैं, they don't do this. वो morphology की staining नहीं करते, and secondly, वो बैठ के 200 sperm count नहीं करते. वो 5 मिनट में read करके report बना के दे देते हैं. Hence, our reporting is faulty. Manual assessment of sperm morphology or semen parameters is a very difficult and time-taking task, which is generally not followed properly in our setups. अब limitation क्या है assessment of sperm morphology? It is visually subjective, inter-observer variability, दो लोगों को बिठा के आपस में उनका compare कर लें, differences आपको नजर आएंगे. Inter-lab variability, हमारी lab, डॉक्टर शाहीन की लैब, डॉक्टर उज़मा की लैब में भी रिपोर्टिंग में फ़र्क होगा क्योंकि इट्स वेरी सब्जेक्टिव. स्टडीज़ कहती हैं कि दिस डिफरेंस इज़ एज हाई एज 40% विद इन वन लैब. सो इतना हाई डिफरेंस एट टाइम्स रिपोर्टिंग के अंदर आता है. Generally, as I mentioned, that morphology evaluation is done with a light microscope, which has technical limitations. वो proper structures of the sperm को assess नहीं कर सकती. Proper method, best method to assess are use of transmission electron microscopy that enables the evaluation of all the structures. The problem is it's a very expensive equipment and is not available commonly. So manual assessment of sperm morphology has its own limitations. How do we classify morphology? Non-systemic sperm defects. These are common defects that you see in your reports. Head defect, mid-piece defect, tail defects जो होते हैं, कभी individual होते हैं, कभी combined भी होते हैं. These effects may be caused by endocrinological disorders such as infections, urological problems, and also endogenous exogenous factors. And these effects may respond well to treatment. But then there are systemic sperm defects, जो basically are characterized by predominant anomaly present in almost all the sperms in an ejaculate. A good example of that is globozoospermia. Another example is macrozoospermia. Generally, patients with these kind of defects, in most of the cases, cannot be treated. Globozoospermia की मैंने slide डाली. We commonly see this in our practices. उसमें sperm have a round head instead of an oval shape, and there's no acrosome on the head. So with patients with globozoospermia, generally the fertilization potential is not there. Now coming to the real part of the presentation. Does form impact function? We all know that subfertile men have lower percentage of normal sperms than fertile men. ये तो हमें पता है. Generally speaking, men have a high proportion of defective sperms compared to other mammals or animals in the species, in different species. So, but क्या ये low morphology impact कर रही है clinically? इसकी clinical relevance है कि नहीं है? Clinical utility of sperm morphology is still debated. There's a dramatic decrease in morphology reference values by WHO, which is a sign of this कि अभी तक हमें समझ नहीं आ रही कि हम morphology को कहाँ ले जाकर बिठाएं. Morphology. Very limited data is available as far as impact of sperm morphology on natural conception is seen. उसकी वजह ये है कि जिस couple ने naturally conceive कर लिया, वो तो husband अपना semen analysis करवाता ही नहीं है. So we don't know exactly कि couples who are conceiving naturally उनके husbands का actually sperm morphology ठीक थी या नहीं थी या किस range के अंदर है. COVAX conducted a study in 2017 in which they actually retrospectively did a chart review investigating likelihood of pregnancy without ART in men with severe teratozoospermia. Teratozoospermia is poor sperm morphology. Usme it's a small study. 24 men with 0% normal sperms were compared with 27 randomly selected men with more than 4% normal sperms according to Kruger criteria. Obviously, natural conception rate was higher in men with more than 4% normal sperms, but almost 25% of the men with 0% normal sperm or severe teratozoospermia also conceived. So हम जो patient को कहते हैं कि जी आपकी morphology is extremely low, you can't conceive naturally. Here are men with 0% normal forms who were still able to conceive naturally in about 25% of the cases. And not only they conceived again, all of them. So उनका एक बच्चा नहीं हुआ, उनका फिर दूसरा बच्चा भी हुआ with the same semen parameters. So this gives you a food of thought कि morphology अगर low है या even 0% है, क्या आप patient को बिल्कुल ना कर देंगे कि हो ही नहीं सकता? Here is a study that shows that they did conceive naturally without any assisted reproductive techniques, any help. Similarly, IUI and morphology. We all know that the sperm count and sperm motility are extremely important in IUI. अगर count एक level तक है, motility एक certain level तक है, तभी IUI करने का फायदा होगा, क्योंकि अगर आप immotile sperm inseminate करेंगे, obviously there's a chance कि वो conception ना हो सके. But is morphology also important in IUI? No consensus for the percentage of morphology of normal sperm is needed for IUI success. Although early studies found that normal morphology was associated with higher pregnancy rates, recent studies have found that sperm morphology did not impact pregnancy rate in IUI. Which means कि क्या हम ignore करते हैं sperm morphology को? So here's a large study, a meta-analysis of 20 observational studies involving 41,000 cycles of IUI, looking at the impact of sperm morphology. More than 4%, less than 4%, and less than 1%. There was no difference in the pregnancy rates. तीनों categories के अंदर 4%, less than 4%, less than 1%, pregnancy rates for 14%, 12%, and 13.9%, respectively. So this is, जब मैंने स्टडी पढ़ी मैं तो सर पकड़ के बैठ गया कि हम तो इतने पेशेंट्स को फ्रॉम IUI कन्वर्ट कर लेते हैं कि नहीं आप IVF फिक्स ही करवाएं just because your morphology is low, although the sperm count and the sperm motility is same, but this large study of more than 40,000 IUI cycles is showing something which is different, that उनका pregnancy rate is same है, चाहे morphology low है चाहे high है, it doesn't matter. Then it goes further. A recent randomized controlled trial found that men with morphology of less than 4%, if they undergo 3 cycles of stimulated IUI with gonadotropins, were as effective in achieving pregnancy as one IVF cycle. Mind you, ये IUI वाले जो patients हैं, इनका count और motility ठीक है. The only parameter that is affected is morphology. But this randomized controlled trial shows that अगर poor morphology है और बाकी दोनों parameters ठीक है, so then 3 cycles of IUI may be as effective as going through 1 cycle of IVF. This is so important in our setup where the patient pays out of our pockets. कि अगर उनको success rate almost similar मिलता है, then maybe we can give it a try instead of pushing them into IVF. So recent data do not seem to show a strong relationship between morphology and IVF success. Now coming to IVF and morphology. We've always believed that sperm morphology is one of the best predictors of IVF outcomes. The Kruger and Tigerberg criteria of normal sperm morphology was shown to be predictive of IVF success, including fertilization and pregnancy rates. Morphology of more than 14% was considered to be with a high chance of success, 5 to 14% intermediate chance of success, and less than 5% low chance of success. However, recent data does not seem to demonstrate this relationship. जो अब recent studies आ रही हैं वो ये इस चीज़ को demonstrate नहीं कर रही. Impact of sperm morphology on IVF outcome is minimum and is only in selected patients, which means coming back to the what I was just talking to Dr. Usma also कि हम लोग 100% patients का ICSI कर रहे होते हैं. We should be going back to giving IVF to the patients also, because end of the day वो natural selection है और उसमें embryo quality वगैरह बहुत बेहतर बनती है, आपकी manipulation कम होती है. Even ये हमारे पास information available है. Most of the clinicians still believe that with less than 4% morphology they should not go for IVF, they should go for ICSI, although जो data है वो कुछ और बात कर रहे हैं. Similarly, ICSI में does teratozoospermia impact ICSI success rates? McKinsey investigated if ICSI improved reproductive outcomes in men with 0% morphology when compared to men with more than 0% normal forms. They analyzed 3 years of ICSI outcomes. 8% of men in this time period had 0% normal forms. The fertilization rates and the pregnancy rates were not statistically significantly different, which means that if you get a sample with 0% normal morphology, you may be able to give that patient a chance of performing ICSI and maybe getting fertilization rate and then pregnancy rate. So even in ICSI, I know in our clinic, we've been turning away patients with 0% morphology कि अब हम कुछ नहीं कर सकते, सब कुछ ट्राई कर लिया, लेकिन अब जो स्टडीज़ है वो कुछ और कह रही है. Another large meta-analysis of all literature from 1986 to 2009 pertaining to the impact of teratozoospermia on outcomes of ART. Authors found that teratozoospermia was not associated with low pregnancy rates with IVF with or without ICSI. While there are studies showing that morphology affects reproductive outcomes, more recent data shows that fertilization and clinical pregnancy rates have been reported in couples even with 0% sperm morphology. So, दोबारा सवाल ये आ जाता है कि is morphology clinically relevant or not? पहली बात, does form impact the function of the sperm or not? Current data do not show a predictive value of sperm morphology. Increase in strictness seems to have decreased the utility of sperm morphology in couples going through ART, and sperm morphology has a poor clinical impact on ART and natural pregnancy outcomes. Something, it's a food for thought. I think हम बहुत ज़्यादा focus करते हैं on morphology, but information, जो recent information आ रही है, and it's not also very recent, it's over the past 10 years or so, जिसमें a lot of studies and randomized controlled trials are not focusing on morphology. However, there are various treatment options that are available. There is clinical management, how to treat poor morphology. We can use antioxidants. आजकल बाहर भी antioxidants की रौनक लगी हुई आपने stalls में देखा है, but companies उसको promote करती हैं, and they have a certain level of impact. Some patients do respond to it. Then there's hormonal treatment, there are antibiotics, and then various options that are available for us for treatment options. So in case you want to treat, there are various options, and then there are some new options also available. Dr. Siraj से जिक्र भी करेंगे जिसमें stem cell therapies और वो सारी चीज़ें आ रही हैं. This is a recent publication in Fertility Sterility Science. This is from 2019. Researchers used embryonic stem cells from rhesus monkeys to generate immature sperm cells known as round spermatids, which they showed to be capable of fertilizing an egg. So obviously, sperm cell generation के ऊपर भी काम होता है. With this, I thank you all. These are my references.